Okay, joining us next is Brian Fulgraff. He is the Community Health Program Coordinator at REMSA in Reno, Nevada. He is a paramedic and EMS educator with over 20 years experience in EMS. He is currently completing a Master of Public Health degree at the University of Nevada, Reno. And today, Brian will cover pediatric pearls and pitfalls. Welcome, Brian.
So good morning. How's everybody doing? It's going to take me just one moment here to get my screen sharing. Everybody hear me okay?
We got you, Brian.
Perfect. Okay. I was a little worried about it there for a sec, but I got it. Okay. Oops. I apologize here. Just one second. Let's just get over there. All right, you should have that now. All right, everybody got that PowerPoint up? I included that for you. It's Lake Tahoe. I know, yeah, there's the lake thing with some of you folks in Erie, so I wanted to just show you. We all seem to have one here. We'll get started this morning. I wanted to talk. I called the lecture "Hot Potatoes: Pre-Hospital Pediatric Care" for two reasons primarily. The first is that I want to drive this discussion around some topics that are maybe at the front edge of the conversation, that are some of those debatable things. And the other is that in any lecture, you really start kind of doing some Google searching, and you start looking for more research for topics. And in part of that, I stumbled across this gem here, which apparently is a food truck in Erie. I didn't know that, but I thought tater and fa la 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 potato was a good follow in and a good lead in on a morning for a lecture. So that's another picture of me in case you can't see me. I did just actually complete that master's in public health, and then I've wanted healthcare innovation as well. And I spent most of my time, most of my career as a paramedic. I still work full time in the field as a ground paramedic. Also spent some time flying, and for anyone that recognizes me, spent some time with the UPMC pre-hospital care department way back in the before time with Mr. Basnak. I have no disclosures, no financial interests from anything that I may lecture or mention during the lecture. We do want to go a couple of places. We want to talk about first just the epidemiology of pediatric emergencies. How often does it happen? How often do we see them? How bad are they? Why do these kids call? I want to talk about something called survival calculations that can help us kind of calm and coordinate and pregame our actions. And then what are the things that we can do? What are these topics that are coming up about different best practices to manage pediatric out-of-hospital cardiac arrests? What kind of things happen during that management that are threatening to the patient's safety? How can we analyze and address those things? And then just some best practices to take care of the other people involved, be it family members or caregivers, to include yourself, the caregiver. So first, just a little bit of epidemiology. How often do these things happen? These are my two kids here. And you probably feel this. So most calls are not pediatric calls. I don't think that's exciting or earth-shattering to anyone. It's actually about 9 to 13% of all EMS calls. And about 1% of those total calls are, and you just kind of air quotes, critical pediatric patients. And a lot of times in research, we define those as patients that required a code 3 transport or code 3 response. And people kind of use different tools here as we go. So that sounds good. We know it's not a lot. We know it's not critical very often. So we can all be thankful for that. But what is it? who do we see and why are these kids calling? And we're going to talk a lot about specific age groups, and particularly when we talk about threats to patient safety, we're going to talk about those kids that are less than 1 year of age. And if we just follow the age breakdown, when you're looking at the priority calls by age, so these are the code 3 responses. Where do those happen when they're cardiac arrest? And you think, oh, wow, I see bigger numbers over here on the left in that neonatal group, that 0 to 28 days, there were 5. And then in that 1 month to 11 month group, there were 18. And that number may not seem huge compared to the rest until you notice that 5 in the neonatal window is a lifespan of 28 days. And that 1 in the 6 to 11 window is a lifespan of 5 years. So significant differences. And the other group that I would call your attention to, the rest of them, they kind of follow suit as expected, right? Where do we see respiratory issues? Well, we see a lot that are young that are associated with cardiac arrest. And then we see this whole big uptick of respiratory problems when we're 12 months to 5 years. And we're talking about things like RSV and snotty-nosed little kids. I think that's a medical one. All of those common bronchiolitis, pediatric type respiratory events. And then you get a little more older and a little more mobile through that 1 year to 5 year, or 1 year to 11 year period. And then you get a little bit dumber from that 12 year to 18 year period. And that's where we saw a huge shift from cardiac arrest to respiratory to trauma. And the kids that we're going to talk about are going to be primarily respiratory distress, but overwhelmingly cardiac arrest. So we're going to speak through the rest of the lecture mostly on that age group. We'll talk about everybody sometimes, and I'll point that out, but generally we're going to speak about these kids that are 5 and less. So we've all been in the front of an ambulance. We've all heard that call. We're going to respond for a 2-year-old unknown if breathing. Right. And we think, okay, we've got to think this out. We've got to plan. Our nervousness, our anxiety, everything just kind of pinged out off the charts. You're the crew chief. You need to control and command this scene. What kind of things do you want to do? And for years, I've relied on something that I call the survival calculations. Now, what I do not want anyone to try and do is to memorize the equations. Okay, they're just good things to write down. They're small and short that, wow, dating. Way back in the before time, I carried a calculator at work and I taped these to the back of the calculator. So if you use a notebook or you use a note on your phone or whatever it is, they're just an easy thing to write down. Don't try and memorize it. And never take a WAG. If you've never heard that before, anybody that's not familiar with a WAG, that is the official definition for a wild ass guess. We don't want to do that, right? So I've got some simple facts. Dispatch told me that this patient is 2 years old. And I want to build everything around the age because that's the fact that I know, right? So if I say, okay, the patient is 2 years old, a lot of my drug doses, it's all going to depend on the patient weight. So I want to pregame a little bit. What do I think that patient weight's going to be? And I apologize here. This is actually a typo. I can just take 2 times their age plus 8 to 10. So that 2-year-old is going to be 2 times their age. So 4 plus 8 to 10. And that's their weight in kilos. So I expect them to be in a range of 12 to 14 kilograms. Their endotracheal tube size is just their age plus 16 divided by 4. That's a pretty common one. So 18 divided by 4 is 4.5. So I would expect that to be a 4.5 endotracheal tube if we're talking about an uncuffed tube. I need to know how far to push that tube in. So I want to know the tube depth. So it's just their age plus 10. So now I'm going to put a 4.5 endotracheal tube at a depth of 14 and a kid that should weigh, anybody remember? I think I just forgot. 12, what did I say he was? 2 years old. So 2 times his age, 4, so 12 to 14 kilos. If he's 12 to 14 kilos, I can do his epidose, right? So I would just say, let's call him 12. He's 12 kilos times 0.1, so 1.2, and you'll notice that's volume based. So I'm going to give 1.2 milliliters of 1 to 10,000 or 1 milligram and 10 milliliters of epinephrine. I take that information, I write it on a big thick piece of tape on a Sharpie, and I stick it to my leg. You can do whatever you want to with it. Don't try and remember it. You're going to forget. And if I have that information and I think about what is the worst pediatric call I've ever been on, what are the things that you need to do right now to settle it down? You need to posture that you're in charge. This is my call, I'm managing it, and I'm showing you that because I've got the information. I'm the one that's prepared, I'm calm, cool, and collected. Because no matter how bad it is, if I know how big of a tube to put in, how far to put the tube in, and how much epi to give, as an ALS provider, I can buy time. I can think about what I'm doing next, and I can come in with that information, with a plan. So I'm on the way there still. I'm thinking about other things, right? What do I need to be aware of here? Well, I want to think about, am I in a system where I co-respond with PD? Because I want to be aware of signs of abuse. And what might those things look like? Well, it may be the nature in the home or the demeanor of the people involved, or items that were left out in the house, or something that you saw in the home that matched the injury pattern, right? That kind of stuff. You have a unique invitation to the patient and an intimate relation during that call that you're the one positioned to see it. So we want to be aware of it. If PD automatically co-responds to pediatric calls, that's wonderful. It's one more thing that you don't have to be as acutely aware of, but we still want you to notice it. Scene safety in all calls is a dynamic threat. There might be some things here that are a little bit unique, right? We have a heightened emotional response of a caregiver, or we may have a unpredictable behavior response of a caregiver that was also the abuser. That may decide to turn, that went from, hey, why don't you check this kid out, to, hey, maybe you're checking this kid out too much, right? And it became a little bit threatening. Or if anybody ever had a pet or worked on a scene with a pet that was feeling particularly protective. These are young, vulnerable children. It's more likely for that animal to attack. And then the other thing, and this goes hand in hand with survival calculations. This is the key to control the chaos. Is think about who's going to show up and how am I going to use these people? How am I going to deploy the team, right? What are my task assignments? Everybody on your team wants to do the absolute best thing for this patient, full stop. They all might have a different plan. They all might have a different idea of how to get there. And that discoordination leads to inefficiencies, leads to poor outcomes. So when I want to establish myself as the leader, what I do is I tell everyone what to do, right? I do it politely. I do it for a reason, but I give everyone a task. But keep in mind, everyone is nervous. So what other people want is for you to give them a very clear, very specific task that they can zero in on. So what I want to do is say things like, Tom, I want you to go start BVM ventilations. That's better than saying, Tom, you're in charge of the airway, right? Because now I don't know what Tom's doing. And it put a little more pressure on Tom because he just became the airway guy. Maybe that's not what he wanted. Maybe that's not his strength and I don't know him that well. Maybe he's not of a provider level that I want to empower him with the full task of airway management. So I want to think out, then the task load becomes important if we think about the system that I'm in and who responds, right? I'm a traditional East Coast, Pittsburgh area provider. So I'm used to EMS designs that are a paramedic and an EMT basic, and the two, you go to a call and you figure it out. And then I moved to Reno at the end of 2018, and I now work in a EMS-driven fire-based system. So the EMS provider is the medical authority, and I have my partner who's usually an advanced EMT, and then the fire department's going to show up, and they're going to have 1 or 2 paramedics and another advanced EMT. So I know that my crew strength here is 5. That's the number of people that I have to engage. If you know that your crew strength is 2, or it's you, your partner, and there's a supervisor coming or a second unit, I can guess, right? So as I'm going, I'm starting to think, who's here? How do I use them? How do I control the chaos? We want to do the best thing. So we want to improve the odds. The odds that we're talking about here are the odds of ROSC. If I want to get this pediatric cardiac arrest patient, if I want them to have an improved outcome, and outcome now, we're talking really about 30-day survival. That's the outcome that matters. We care less and less about ROSC, right? But we're still going to measure this. So what kind of thing gives you better odds? Well, if I give epinephrine to a patient, the odds ratio, right, that kind of the how likely it is, how much more likely it is that that patient gets ROSC goes up about 75 times. Bystander CPR increases the likelihood of ROSC almost 13 times. Age is predictive of ROSC. The younger, the better. Or I'm sorry, the younger the worse, but particularly for those less than 1 year of age. So the younger you are, the less likely you are to achieve ROSC. And then the last one, or I'm sorry, AED placement, also kind of a low level effect. And it wasn't about AED use, it was simply someone that was engaged in the resuscitation enough to go get the AED, bring it back, put it on the patient, usually in tandem with bystander CPR. Time from collapse to EMS arrival is also predictive. And while we're thinking of what's the outcome that matters, right? Is it ROSC? And we start to say, no. The outcome that really matters is, does this patient leave the hospital? And or we kind of say this differently sometimes, is the patient alive at 30 days, what we call 30-day survival. So the only one of these things that increased the likelihood that someone was going to walk out of the hospital may not be the one you think it is. The only one that mattered is how close you are in the big box with wheels. It was the only statistically significant variable that correlated with hospital discharge, or statistically significantly correlated, and also clinically. When they did the numbers and you look at this, you would say that for every minute from collapse to ambulance arrival on scene, and we could really even correlate that and stretch it out to arrival at patient side, results in a 5% decrease in the likelihood of achieving ROSC, which is bad, and a 12% decrease in the odds of survival to discharge, which is worse. So then you have to step back and say, well, how can we improve response times? And if you thought drive faster or buy faster ambulances, skip that one to the next answer that you thought. We don't want to do anything that compromises your safety. So what kind of things can we do that are pretty straightforward and would also get us there quicker? And one of the common places that we make mistakes is, how did we as the provider prepare and be ready and make our readiness for the call, right? Are we set up to be at work today? Are we set up to perform effectively and efficiently so that we can have good response times? Are our brains working so that we can route the right way? We have all made mistakes going to a call, right? But this is showtime. And we want to make sure that we're taking the best route to the best place because we're familiar with our area. We know about road closures and traffic conditions, and we use that knowledge to our advantage. Our leadership teams and our management teams have thought through deployment models or deployment strategies. Some people like fixed service. Some people like system status management. It depends on the number of resources, the expansiveness of your response area, the beliefs and commitment of your leadership team, what that deployment model might look like. But we also review and reflect on whether or not that model is effective. And if it's not effective, we have to be willing to face hard facts and make necessary changes. The other piece of this too, the final piece of this, to my mind, is a readiness factor that is in most systems primarily placed on the crew. So we have, and I would think you have, pretty much every place I've ever been has some type of special pediatric setup, whether that's a pediatric bag or different pediatric roles. All of those things work in many, many, many systems. And myself at Remsa, we have a full-time logistics team. So we don't even check or stock our own ambulances. We come back, somebody does that at the end of our shift. We come in for work, we jump back in and we go again. And at the end of the day, they repeat that. But if that was what I did every day, and that pediatric bag is sealed and checked once a month, or it's managed by a logistics team and I don't ever open it, how familiar am I and how ready is that equipment? I know what I think is there, right? But I don't know that it's there because I've never looked at it. So our readiness, our equipment readiness, these are all things that can improve that response time, decrease the time from collapse to your arrival, and improve the odds that patient survives to hospital discharge. So in one of these settings, how we get there truly matters. And that's maybe not true in a lot of EMS responses. We see less and less emphasis on or more and more emphasis on non-emergent response. Understand that minimal time saving doesn't typically matter. In this case, that's a pretty different situation. So we're on the way. Crew's going. We've got our survival calculations. We've thought it through. We've done task assignments. We've positioned ourselves to be ready, to be the leader, to maximize the patient's chance of a good outcome. Now we get there. We want to think about how do we assess? What does this look like? And I'm going to go through this part pretty quick because this is just PALS. So if you've ever taken a PALS course or a Paris course, or really any kind of pediatric assessment course, someone at some point in your life has mentioned the pediatric assessment triangle. And the pediatric assessment triangle is wonderful. It helps us decide how sick somebody is and how emergently we need to intervene in that care. And you can do most of it from 5 feet away without ever touching the kid. So we start with just how do they appear? How do they look? And if I am 5 feet away and I'm looking at someone, pediatric patient, adult patient, doesn't matter, I can see a certain number of things about them, right? I can see their muscle tone. I can see their behavior, their interaction, their engagement with their surroundings. I can see their gaze. When we're talking about children, we think about their consolability. How responsive are they to their caregiver? And then I switch over and I say, okay, let's look at their work of breathing. And your biggest tell in work of breathing is what does it sound like? And I can hear that from 5 feet away, right? If I hear stridorous sounds, what are usually on inspiration, they're that high-pitched whistling sound. Stridor tells me that that's probably an upper airway compromise. And I learned that without ever getting to the patient. Wheezing, typically an expiratory sound that sounds like wheezing, usually points towards the lower airway and lower airway disorders. So things like bronchiolitis, things like asthma generate wheezing because of the constriction and accumulation of mucus in the lower airways. Grunting respirations are also particularly concerning. It's increased expiratory resistance or forced expiration. So this patient is working to breathe on all sides. It's hard to pull air in, it's hard to push air out. They're recruiting muscles for everything. How's the patient positioned? You know, are they lax and sitting back? Or are they upright and rigid in a tripod position? Tripod positions are really fixed. We do it for a reason, right? If I come forward a little bit and I sit up tall, what I'm doing is creating a body position that my diaphragm will move down, right? My giant muscle pulls down because that's what pulls air in. And in this position, it can do it with less resistance. Other positions we don't typically notice so much unless we're talking about like older patients. They say, well, when I lay down, it's hard to breathe. And that could be two reasons, right? There could be fluid there, but lying down is also harder to move your diaphragm. So both of those things, that positioning, those sounds, the presence of other muscle use, right? So are they retracting? Are their muscles pulling so hard it's pulling their skin in around their ribs? They have nasal flaring because they're trying to create bigger spaces in which they can pull air in with less resistance, right? All of these things are about doing less work, spending less energy to get oxygen. But you're also in an oxygen deficit, so you're going to be tachypnic. You're going to be breathing faster, right? So it's noisy. you're in a purposeful position. I see the extra muscle use. I see you doing things to decrease air resistance, and I see you breathing hard. You have a significantly increased work of breathing. If I'm talking about your circulation, it really is as easy as how do your pulses feel and what's your skin color? Are you pale? Are you mottled? Are you cyanotic? Do you have weak or absent peripheral pulses and really strong core pulses, right? So when I start to get a little bit touchy, I can get a better idea of circulation to the skin. But just from 5 feet away, skin color, muscle tone, work of breathing, right? I know a lot about your mentation and whether or not you seem to have a respiratory or a cardiac problem or both. And this also comes from PALS, this idea of evaluate, identify, and intervene. If you're older, it used to be assess, categorize, decide, and act. And what PALS was talking about was doing cyclic, repetitive assessments. So when I met a sick child and I applied a PALS algorithm, I would look at them, I would use the pediatric assessment triangle, and I would say, oh, they're either sick or they're not, right? They either look really bad, they have a poor appearance and a huge work of breathing, and they're sick, or they have a poor appearance and flaccid muscle tone and pale skin, and they look a little bit cyanotic, and they're sick, or they're not, right? The kid's sitting upright, he's got a fever, he's a snotty-nosed kid, he's not working hard to breathe, his skin color is still good, he's a little bit hot to touch, maybe he's febrile, he's not sick. So we apply that as level 1. And then we can evaluate a little more, right? We can do another assessment. And this time, if we evaluate, we do a physical exam, we do some vital signs, we've got some lung sounds, we touch the kid, we learn some things with our hands, some tactile engagement. And now we think, oh, okay, and in PALS, we follow this through, you were sick or not, you were in respiratory or shock compromise. If you're in respiratory, and you don't have to remember this, by the way, we're just going quick review. If you're in respiratory, it's either failure or distress. And then we figure out of which flavor. Is it upper airway, lower airway, parenchymal tissue disorder, or disordered control of breathing? And I would pick the appropriate management. On the shock side, I wouldn't say, are you in failure or distress? I say, is it compensated or hypotensive, right? I learned that from looking up your minimal accepted systolic pressure, or writing down on my card that it's 70 plus 2 times their age. So I can get that information, compensated or hypotensive. Then I want to think, okay, what shock syndrome is it? Is it hypovolemic shock? Have they had a bunch of metabolic loss or a bunch of blood loss? Is it obstructive shock? Things like pericardial tamponade and tension pneumothorax. Is it a cardiogenic shock? Or is it due to some underlying congenital anomaly or some acute dysrhythmia? Or is it a distributive shock? Things like sepsis and anaphylaxis and neurogenic, where the vasculature is large. There hasn't been any change to the fluid volume. It's just that in all of those, the vasculature is dilated. So people are in a relative hypovolemia, also a shock state. So we want to do that. But to get through that, we might need some tips, right? If this patient is 2 years old, you might be thinking, great, I don't like kids. I don't want kids. I don't want to talk to kids. I don't know anything about these people. So what kind of things can I do that can make the assessment better? Or just things that are kind of common mistakes. And the first one is, I would say, is if you're going to do this evaluate, identify, intervene thing, remember, this doesn't really fly in some of these assessment tools, or rather the assessment tools don't really fly in critically ill patients or in trauma patients. So we think of things like, okay, really build that rapport and start with their toes and do minimally invasive things first. If you fall out of a window, get hit by a car, or in cardiac arrest, we don't do those things, right? It's showtime. I have to get in. I have a more rigorous process to follow. But in the 99% of kids that are stable, that we really want to involve the caregivers wherever we can. And we should actually do that And I know it's a little more controversial, but even during resuscitation, the presence of caregivers can be therapeutic. And once you have the confidence to say, I got this, you mind a lot less if they're there. Be observant. I don't mean observant of the scene. I don't even mean observant of your partner or your care team. I mean the patient. Is the patient's skin signs changing? Is their work of breathing changing? If we just keep observing the pediatric assessment triangle, we will catch the change in the patient. Yes, children have a lower means to compensate. Yes, we could do a better job of recognizing early compensation rather than throwing our hands up and say, we missed it, they crashed, right? Constant reassessment of the pediatric assessment triangle. Do not lie to kids. They're going to get their reaction from your reaction. So be calm, be collected, be prepared, be honest. Don't say things like, it won't hurt, because sometimes it hurts. Don't oversell it. You're not trying to make the pain sound terrible, but be honest with the child about what the expectation is. Don't tell them it's going to hurt when you do that IV, and then go to the airway seat and get some IV equipment ready, right? And let them stew on it and panic and vagal down because they're nervous and you created space for anxiety. In infants or individuals that are still of thumb sucking age, be aware that that's their dominant hand. So we ask adults a lot of times, hey, we're going to put an IV in. Are you right-handed, left-handed, right? Because it's inconvenient. It's still inconvenient, even if you don't really have anything important to do with your hands. So your thumb sucking hand is dominant. You should try and avoid that. Obviously, do the least invasive things first. Start small, build trust, build rapport, use distraction techniques. You have to update them over time. My go-to distraction technique for a long time was that I knew who lived in a pineapple under the sea. Absorbent and porous and yellow sea. If nautical nonsense be something you wish, right? I learned the song and I knew to drop on the deck and flop like a fish because it built rapport with my patient. If you aren't doing, I suggest maybe you try at least one time, download some games, download some movies to your phone, hand it off. It's a fantastic tool. Some companies provide ambulances for that reason. Way back in the before time at Southwest Ambulance 2 decades ago, we built a whole ambulance and put a TV and an Xbox in it, called it the Kidulance. It was actually pretty cool. But the idea was that if you decrease the stress, decrease the anxiety, create a safe, comfortable care environment, you can build rapport and get better outcomes. So we did our assessment. We've got a whole thing going on. We know which disease state we're in. We know what our care plan was going to be. Anybody ever stopped for a minute and thought, we need to go to like a specialty children's hospital, or can I go to the smaller hospital that doesn't really have a peds floor and they definitely don't have a peds ICU? And it's taken a really long time, and that is George. And which way do we go, George? Because that decision has been largely unguided. So there is a group, they released something called the consensus criteria that is meant to assist emergency department physicians in deciding who can stay at the outlying hospital and who needs to get transferred to dedicated pediatric centers. The team was made up of 11 individuals. They represented both pediatric emergency care and EMS backgrounds. And what they did is a modified Delphi survey where they have to reach consensus agreement to keep something on the list. And all of the 13 criteria that survived have at least 80% agreement amongst the 11 experts. Their intent, because when you read it, it seems like we've got some crazy things on here, right? ICU admission, interventional radiology or surgery. I don't run into that one too much. Those are things that really don't apply to me. But this framework was meant to be the basis for an EMS pediatric patient navigation guideline. And really what you're looking at is something that you can apply almost without exclusion right now. right? We know if airway management, CPR, electrical therapy, PALS medications, respiratory assistance, we know if those things are happening. We don't carry two different classes of seizures necessarily, unless you're in a place that's doing like a benzo and ketamine, you would think of as a dissociative. So that's a second class. But in most places, that's probably not applicable. IV antibiotics, maybe we're not doing, but applying sepsis criteria for suspected sepsis patients, we certainly are. So I would count that one as well. We can readily identify by collecting an HPI, whether a patient's immunocompromised or previously had cardiac surgery. And we will know the moment we meet the child, whether they are tech dependent and tech assisted. And those types of patients should go, when practical and when possible, to the initial treating center. Those patients that are receiving care for extremities, so I apologize, that was the immunocompromised, cardiac surgery, and tech assisted, should really go to those treating and implanting centers. The rest of them should go to our closest hospital with a pediatric ICU, right? Someone that can manage that patient through the duration of care and provide better specialty services just through the number of reps and through pure iteration and exposure. And that resource is valuable. So I want to talk gears a little bit and talk about patient safety, but I don't mean, I mean that specifically really in the domain of care. So we had walked through the dispatch and then we walked through the assessment, and think of this as the walkthrough of the treatment and transport, but without really reviewing treatment and transport. Because what we want to talk about are these things that we call UNSEMs. I didn't name it. I don't know who did. It's a little bit wordy. Unintended injury, near miss, suboptimal action, error, or management complication. Sounds like it includes a lot of pretty crazy stuff. But it was a retrospective chart review of code 3 transports. So that was our snag this time for critical patient, is a code 3 transport from 2009 to 2011 for patients less than 18 years of age. And what they did is, you're going to look at here as we get to the bottom, is a little bit of odds ratio, and I'll come back and explain that stuff. But they reviewed all of these charts, and you can see it was 378. And 265 of those charts, 70.1%, contained at least one UNSEM. There are a lot of errors, suboptimal outcomes, and patient-threatening consequences that occur in pediatric patients, all comers less than 18 years old. Take that, right? Take an error rate of 32.8%, or a potentially unsafe delivery, in this case of 23.3%. Zero that into patients that are just in that 29 days to 11-month period. Heightened window of, or one of the two heightened windows of cardiac arrest calls. And that odds ratio goes up to 3.3. The odds ratio is the increased likelihood. So it's 3 times more likely, over 3 times more likely, to make an error in that patient versus that whole population of one, versus the whole remaining population of 1 to 17. In instances where you're doing resuscitation, CPR, advanced airway skills, 3 times more likely to make an error. So we start to understand when and where and why it's happening, right? Less than 1 during resuscitation. Cardiopulmonary arrests are 8.5% of total cases. So if we just zeroed in there, right, it's a 10th nearly of total cases and over a 1/3 of severe consequences. And then the burden on that neonatal group is even higher than the burden of errors in that 29 to 11-month group. So it just stresses, again, kind of over and over, where the errors occur. And if we know where they occur, then we can work on designing systems to address them, right? So you've got your dumpster and you're trying to prevent it from becoming a dumpster fire. Now, I don't know that that can be done in the photo, but with critical children, if we think about the who, the where, and the when, we can prevent that dumpster fire from occurring. The errors that occur on a scene have a cascade effect that are detrimental in numerous ways. So as soon as I make an error, I'm the provider and things are going wrong. I've got the wrong equipment size, or I've got the wrong drug dose, any of those things, I'm not going to get the outcome that I expect. And if I don't get the outcome that I expect, it increases my emotional stress in a situation that is already incredibly emotionally stressful. My emotional stress is going to get passed on to my crew, most likely, because I'm a human. And if I'm stressed, I'm losing my calm, confident posture as team leader. My crew's becoming stressed. People are losing direction. I'm focused a lot on what's going on, the mistake, trying to figure it out. Why am I not getting the outcome I want? My crew's losing their task assignment, or they've completed a task and have nowhere to go. Now they're feeling maybe a little bit useless, and everybody is spiraling. So how do we navigate that, right? How do we overcome some of these problems, some of these errors, now that we know where they are? Well, one of the first things is we have to practice good communication. Communication between the team members, between you and the patient, between you and the caregivers, and between your team and you and the hospital staff should always be complete, timely, and efficient. If we're complete, timely, and efficient, we can reduce errors. We can improve continuity of care. We can improve patient and caregiver satisfaction. We can improve the harmony, efficiency, and delivery of care from the care team. Everything gets better, right? So we always think, is it complete? Is it timely? Is it efficient? Because they looked at this. The Joint Commission went into the hospital. They look at handoff communication between pre-hospital providers and in-hospital providers, and between department to department within the hospital. And they said, oh, hey, there's one. And they said, you know, how often does a communication breakdown contribute to a medical error? That occurs 80% of the time. 80% of medical errors are thought to arise from some degree of miscommunication. Now, if we apply that back to what we were talking about, we were looking at some of these errors are medication error driven, that have severe consequences, or it's the wrong equipment size. Do you as a team member consistently verify, this is the equipment I think it is, this is how I got that size, this is the medication I think it is, this is the expiration, this is how I got my dose, right? Do you say that part out loud? When you're on the scene and you're preparing drugs, and we use that case example from our survival calculations, does someone say, hey, this child is 12 kilos, this is 1.2 milliliters of epi, 0.12 milligrams, that expires in August of 2023. Go, right? That will minimize mistakes. It'll minimize education or medication errors. You should do that with every patient. People get tired of me saying, here, it's 4 milligrams of Zofran, it expires March 24, you know, okay. But if I do it every time, it's a habit, it's a heartbeat. When the pressure's on and the stakes are high, I do it because I do it when the pressure's off and the stakes are low, right? I shouldn't say low. Zofran's low unless, you know, you mix it up and give them fentanyl. You know, I guess the scene is less chaotic. The environment is less severe, it's less hostile. So we started thinking about, can we improve this? Can we increase crew education? Can we improve gaps in education by simulation, simulated practice? And that answer is definitively yes, we can, right? But we want to know where we start. So this is a simulated observation. This is a trial that was completed a handful of years ago. Not horribly many, somewhere around 5-ish. It's been done in the past. This was a repeat. They brought in 2-person crews, 45 2-person crews that were familiar as crew members. They were tenured as EMS providers. They had varying degrees of rest since their last shift. And they kept track of all of those things to see the influence of fatigue and shift duration. They used their own equipment and drugs. So they are familiar, or should be familiar, with the equipment that they had available. They walked into a simulated episode in which the pediatric patient, it was an infant patient, so 1 year, 30 days to 1 year, they presented with altered mental status, experienced a seizure, and progressed to respiratory arrest. They were observed for their behaviors, and then they were given the opportunity to provide feedback about what happened. And what happened was really high rates of equipment failure, medication misdosing, and missed assessments. So 54% of them didn't use an OPA. Sometimes that was because they didn't know where it was located. They didn't size it appropriately. What they found in their bags for medications, maybe it was a vial, didn't work. 51% measured a glucometer. Some of them said, well, the glucometer wasn't in the pediatric bag. And I didn't bring the other bag with me. So I was going to do it, when we get to the truck, or when we're going to do this, or whatever it is. But now we're dealing with the seasoned kid who's altered, who's arresting, and we didn't have the equipment there because of how it's engineered, how we designed it. A couple expected drugs, diazepam or Versed, so Valium or Versed for the seizure activity. When we score their correct dosing, kind of the standard that we use is what is the calculated and expected dose, and are you within plus or minus 20% of that? Valium was given incorrectly 47% of the time. Versed was given incorrectly, was given correctly 60% of the time. Valium was given correctly 47% of the time. So 53 and 40% error rates respectively. When we see an error like that, and we're trying to think through a root cause analysis, what we want to do is just ask why over and over and over again until we can't get to any more whys. So I'll start you on this process, and then you can work through it on your own, because you might go in different directions, right? So if we said, our why is that midazolam is incorrectly dosed 40% of the time, right? That's what we want to understand. So why does that happen? Well, that might happen because we made an incorrect weight estimate or an incorrect calculation. We weren't familiar with our Broslow tape or length-based tape or PD wheel or reference card that didn't have the information we thought it did on it. So if I don't know how to use it, maybe I'll just try and remember. And a lot of people took a WAG and they didn't remember the medication dosages. Some people knew what to do and found it really hard, as most of us do, to do math and conversions and measure volumes correctly while under stress. And this is simulated stress. There's also a persistent failure, like we were just talking about, to verify medication doses and volumes and how we got there quickly with our partner, with another caregiver on the team, so that someone else has an opportunity to say that doesn't sound right, or I know that's not right. Right? So, but now we have to step back again and say, okay, why do those things happen? Well, maybe we don't offer enough or consistent enough or ongoing pediatric training or simulation or skills practice. Maybe the providers have a lack of experience with the equipment, or obviously we had some stuff that was broken because our store and tag system isn't working out the way that we want it to, right? People don't know what's in there, or the bag got tossed and the stuff got broken. Nobody knew because we don't put our hands and eyes on it every day. So you say, okay, well, why do those things happen? And that will take you to another question. Maybe your answers are, well, we have to prioritize education in other domains, or, our staff is strained right now. Our call volume is very high. We have provider shortages. They're already checking the bag, the house bag, the monitor. They got to run 20 calls in 10 hours. And there's no way that I can get them to get through this pediatric bag as well. And then we would step back and say, well, why again? And then why again? And then why again? And eventually we'll get to what is the root cause of the issue. Now, in this example with Versed, they didn't actually get that far. So Versed is given incorrectly 40% of the time. And they said, well, why? These guys have a Broslow tape. They're going in. The information's on the card. What could possibly be going wrong? Well, here was the card. So I don't know what you guys have. The Broslow tape was updated a year ago, 2 years ago, perhaps. This is the older version. And I like this because if I said, okay, you've got a Broslow tape, you laid it out, your patient is unresponsive, they landed in the orange zone, we want to give them dextrose, we just found out their glucose is 20, and I scroll down and it's, oh man, 13.3 grams. So what are we going to do? How do we give 13.3 grams of dextrose? Because all I have, there's this national drug shortage, and all I've got right now is an ampule of D50. Child is unresponsive. Parents are watching. They're getting angry. You can hear them behind you, right? Does this crew know what they're doing? Our kid's going to die. And here you are trying to do some math. Because it said 13.3 grams. Oops, I made an error. I wrote milligrams and shouldn't have. I apologize. So the first thing I've got is I've got an AMPA D50. So I've got to take my AMPA D50 now. I've got to make it into D10. And if I hadn't thought out how to do that in advance, that's some math all its own. But if you've got it and you got a 250 bag, right? I can take 50 cc's out. I put my AMPA D50 in. I shake it all about, and what I made is D10. And you can see that calculation, right? So the 25 should be grams. So actually all the milligrams should be grams. So once I do that, when I take the 50 cc's of saline out, I put the 50 cc's, that AMP has 25 grams, not milligrams, 25 grams of dextrose in it. So now I have a total volume of 250 cc's divided by my drug concentration of 25 grams. And I can see that there are 10 cc's for every gram of dextrose when I use D10. So if I want to give 13.3 grams, then I have to multiply that. And I get to 133 cc's of D10 from that reference card that was going to make it easy for me, right? But if I hadn't thought through this calculation, if I wasn't prepared for this calculation, could you have done that on the fly? If you're used to a bag of D10, you open up the drug box and, oh man, there's a shortage. It's an ampule D50, right? If that's the reference card you had. So that we knew that was a problem. So we addressed the why. And a lot of you've probably heard of the Hand-Tevi system. Hand-Tevi is a pediatrician who makes more money selling this probably than he does doctoring at this point. Because this is a relatively simple system, you can use the hand guide for the whole thing. But the part of it that I'm really interested in is it's volume-based dosing. So it's what are my standard concentrations and how much of that do I have to give? So an EMS system implemented this. And they went back, they want to say, okay, does it work? Does it matter if we use that orange Broslow card that just says 13.3 grams? Or does it matter if we use one that says dextrose, D10, 133 cc's? And the answer, as you would expect, is overwhelmingly yes, it matters. 483 drug administrations against 375 unique patients. And what they found in the Hand-Tevi system, these are all patients less than 13 years of age. They compared it pre and post. We went from 51.1% correct to 89.4% correct. A greater number of exact doses, which you would expect because it's telling you the exact volume. The majority of errors remained. even with a volume-based system in patients less than 1 year of age. Stress, anxiety, calm, confident, right? These things influence our behaviors, influence our mistakes. Survival calculations, being prepared, knowing your reference is going to drive that number down farther. Our medication delivery is going to be more accurate. So what did they do? They also addressed the why, right? It is not surprising that the new iteration of the Broslow tape looks like this, right? And what do you see here? Well, I see that in my D10 for this patient in a purple color, it would be 5.25 grams, and that was old school, and we would be in the same spot. But with D10, 5.25 grams is 52.5 milliliters. Just how we calculated the same math, right? But it's a lot easier. It's a lot more reliable. I don't endorse any particular system, whether it's Antevi, whether it's Broslow, whether it's some pediatric wheel. What I endorse is volume-based dosing. What I ask is that you engineer a program and an EMS system that uses volume-based dosing, if you're not already, because it will improve your patient safety and medication efficiency. And you as the provider need to know what's there and where it is. Pulling out a Broslow tape and searching to find the medication you're looking for and being unfamiliar during a cardiac arrest really undercuts that confidence, right? That's your reference material. Know how to use it. Know what you use. And then when mistakes happen, and they do, be it an organization and thrive in an organization that believes in a just culture. And a just culture is critical for error reporting, right? Just culture recognizes that errors arise from a lot of different sources. It might be the way equipment is stored. It might be the way we operationalize our pediatric response. It might be the type of equipment that we have. It might be how we chose to invest our time and dollars for training this year that led to some error. But it's the intention over the outcome that we gauge in just culture, right? Was your behavior trying purposefully, thoughtfully to do the right thing, and the wrong thing happened and we found some way for it, even if that way is just a human error? Just culture says this isn't malicious, this is an accident. And we can't get better. We can't redesign systems. We can't re-engineer safety protections. We can't re-educate humans. We can't change the supplies on the ambulance unless we know the errors are happening. And if we don't have a just, open, inclusive culture, no one is going to tell us the errors are happening. So it's another critical part of system design to really improve pediatric care delivery. So let's get to the part that nobody wants. And we'll talk about just a couple quick pearls here, specifically about cardiorespiratory collapse, right? The cardiac arrest kid, the impending cardiac arrest kid. So we'll go back to NEMSIS data. NEMSIS collects all the numbers and tells us what EMS did last year. And in 2020, there were 15.4 pediatric out-of-hospital cardiac arrests per 100,000 EMS responses, of which the majority were older children by virtue of how long that window is, right? So older children, anybody 8 to 18, they were 35, 36% of the cardiac arrests, oftentimes driven by trauma because that's their profile. Younger children, 1 to 8, smaller group, only about 22% of cardiac arrests, oftentimes now respiratory event driven, congenital anomaly driven, drowning driven. Drowning is the #1 cause of death in children under 5. And then infants, about another 20% of all out of hospital arrests. And here, we talk about those number of different differentials. Again, drowning is high, respiratory complications are high, child maltreatment and abuse is high, but they represent about 1 in 5 of those calls. So the biggest thing that I can suggest, the biggest thing if you're not doing it today, that will improve your patient outcomes and your patient care, is stay in the room where it happened, right? Pediatric cardiac arrest survival in general is less than 10%. I've witnessed a lot of grab that kid, push on that kid while we're jogging to the ambulance, jump into the back of the stretcher, usually at a dive, somebody guns it, right? And we are 99 miles per hour, 79, we don't set up a drive cam. We're 79 miles per hour all the way to the hospital. Is that good for outcomes? Well, if our median outcome was 10%, and we look at scene time correlated with survivability, scene times less than 10 minutes had a 5.3% survival to hospital or 30-day survival. Scene times greater than 35 minutes, 6.9%. Scene times in that management zone, 10 to 35 minutes, drove the numbers up because they were the 10.2%. That was the majority, and that's where the majority of effective resuscitations come from. If you've ever seen the scene time survivability curve, and it correlates duration of scene time with likelihood of 35 or 30-day survival, in adults, it's kind of just what we've planned for years, right? It's stay there for 10 minutes, take another 10 minutes post-ROSC, your scene time might be around 20 minutes, and that's the sweet time for outcomes. And then we made one for pediatrics, and fun fact, it looks exactly the same. Scene management, where it happens. A different EMS program instituted a protocol similar to what you have in Pennsylvania for a pediatric crashing patient, this peri-arrest child. We are going to have this company-wide, region-wide protocol, just like we do statewide in PA, that you're going to stay there, you're going to provide immediate resuscitation on scene. And they compared survival over pre and post intervention. Now, the number is relatively low. It's only 94 patients in the total enrollment, and you have to segregate that between pre and post survival. But when they stayed, or when they grabbed the patient and ran, their survival was 0%. And their mean time, this one gets me, their mean time to first epi administration, 16.6 minutes. When they said, get there, stay there, room where it happened, get the work done, their survival, same patient population, survival to 30 days, was 23%. Their mean time to epi administration dropped from 16.6 to 7.6 minutes. Those differences are astonishing. And those differences, if they haven't already impacted your care, if that protocol hasn't sold you, those differences should make you stop and think, okay, I've got to build myself in terms of my confidence and my capability to direct this team and manage this scene, because staying there and confronting the pressure and the stakes of the emotion of being there gives this patient the best chance of survival. And that's one of the best things that we can do. Our resuscitation plan might involve some airway management. So let's roll back another year and check in on some NEMSIS data. 2019, we saw 1.1 million pediatric patients. I believe in the Erie area, you guys saw 1 million, everybody else, 148,000. So you were very busy, but that's not a big number relative to total population, still about 10%. And then you take that number and say, who's really sick? How many airway skills did we perform? It's not very many, right? Under 23,000, less than 2,000 for every 100,000 encounters. And when we do these skills, what do? Well, usually we bag someone. And usually that's a good option and often the best option. If we talk about endotracheal tube intubation, we don't do that particularly much, right? But we actually had a pretty good number, 75%, not where we want to be, but a decent success rate per patient. That number falls precipitously among neonates. Hello again. I think I lost everybody for a sec there. Are we back here?
Can hear you, Brian.
Okay, perfect. Let me get set up. I got a breakout room invite that felt misplaced, but I wasn't confident.
Sorry, you shouldn't have, and I can't get rid of it.
Oh, that's okay. No problem. I got it now. I can ignore them. So anyway, so we're talking about this. I'm back, right? You got the slides?
Yep.
Okay, perfect. So usually we're talking about bag valve mask ventilation, and then we talked a little bit about endotracheal tube intubation, and we got to bring in supraglottic airways too, which we actually did the fewest in 2019. But this has been kind of an evolving thing, and they did still have the best success rate. Now we get a complication most often of vomiting. And supraglottic airways are pretty good, but they don't isolate the trachea. So we do want to be very aware of having suction ready. If we're going to do an intra-intubation attempt, if we're going to do endotracheal intubation, we need to have that suction up. If we're doing a supraglottic and it's not isolating the airway, we need to have that suction ready. If we're doing prolonged bag valve mask ventilation, then we're going to insufflate a bunch of air into the stomach without intent, right? It's just we are all amped up and we're squeezing the bag hard and we're probably blowing too much air in. And when we do that, any air that goes into the stomach will show itself again to you in the form of vomit. So that hyperinflation, that excessive volume, excessive rate that comes from, and I always use the expression, providers are catecholamine toxic, right? There's so much epi, there's so much adrenaline that we are just cranking this bag down, 120 times a minute, and all that extra air gets in the belly. So we just want to be very, very careful of who we've got using the bag valve mask, how they're doing, because that's going to be our most common skill. And it's a skill that too often and historically we've handed off to the newest guy because it sounded easy to say, go squeeze that thing. But we really should be using a two-person technique. It really should be somebody that is well qualified and well versed and familiar with airways and familiar with bag valve mask technique. And we need to practice this stuff all the time, right? If we as an EMS community are only bagging 4,000 kids a year, and we only did 29 needle cricothyrotomies, and we only intubated 3,000 people, then how do we offset that deficit? Because frequency and proficiency correlate. And if I'm not doing something, I'm not staying good at it. So we have to practice. All practice is good practice. Unexpected verbal scenario, good practice. Low fidelity mannequin that you walked by on your way to Starbucks and put a supraglottic in, good practice, right? Everything is good practice. Just keep practicing. Our other big intervention here is going to be an IO. IOs are very, very successful devices. We use them with pretty good proficiency. When we get to that patient less than one, all of a sudden we take that group out from all the other pediatric patients. And again, we say, okay, less than one compared to 1 to 17-year-olds. How did we do? How functional were the IOs? Well, we're talking about 25% versus 75%. The insertion attempts go up to 2 from 1. The duration of function, because of the size, the placement, the brittleness, and the integrity of the bone, comes down to 20 minutes from 35 minutes. So we were less likely to get it to work. When it did work, it was less likely to last. And if we did get it, it took more tries. These frustrations, these difficulties, Maybe it's lack of preparedness. Maybe it's lack of the right equipment. No matter what happened, maybe it was just a mistake, a one-off human error, right? I'm nervous. I'm holding an IO gun and I can't stop shaking my hand. It's difficult. What system can we engineer? What can we do different? What can we improve, right? We're going to do these skills. We want to be aware that this is a skill that that guy that's got a bunch of IOs in maybe hasn't done this one, right? And maybe is a little bit nervous and maybe needs a little bit of oversight. But it's a good tool. It should be an early tool because it allows us to get early medications on board. And it turns out that probably matters, right? Epinephrine is just this cursed drug of, man, it is the mainstay to like, I'm not sure anymore. So we in the United States use the ROC Consortium, the Resuscitation Outcome Consortium, which I guess if you say ROC Consortium is a consortium, collects tons of national data on cardiac arrest outcomes. And really what they do is a bit of data mining, meaning they come up with all these secondary analysis and they'll just say, well, gee whiz, I wonder if we take that big pool of data and we figure out, let's filter out, so it's just patients that are in non-shockable rhythms. Okay, we filter those out. How about just pediatric patients with non-shockable rhythms? And then let's look at the timing of when those patients received epinephrine. And for each minute from arrival, you're starting to get this whole time thing, right? How fast did we get there? How fast did the epi happen? Each minute from when we got there until we got the epi on board, 4% decrease in 30-day survival. The epinephrine that was given late, those patients in general had a 9% lower odds of survival. So much like with adults, epi early, specific to non-shockable rhythms, had a clear and proven survival benefit. We are always immediately confronted with epi data from Japan. No different here. Same kind of thing. Nationwide group in Japan, 1 month survivability. Now, they did not have any regard for neuro-intact survival, which is our typical standard. It was just, are you alive? Your neurostatus didn't matter. This was about 4,000 patients, uniquely, because it is kind of a data mine, it's secondary analysis, so you can sort it however you want. They said, let's just talk about patients that are aged 8 to 17, because they most represent the adults, and that's who we were seeing info that, maybe it wasn't so valuable in adults. Less than 8, your airway anatomy is still different. You're not just really a tinier adult, you're much more nuanced. But that 8 to 17 group, maybe a little bit less so. So to give you a sense of how things were going in Japan and their protocols, of these patients, almost 4,306 received epinephrine. The other almost 3,700 did not. And there was no statistical difference in who survived. But much like what we already talked about here, those individuals that received epi had a greater incidence of ROS. I think our odds ratio showed it at like 72, 73 times greater, right? It's a significant increase. When you give that adrenaline, you can often get ROS. That doesn't mean it's sustainable. That doesn't mean it's associated with survival. And that doesn't mean there's a positive neuro outcome associated with it. And those are all the markers that we've switched our focus to. So with that switch comes some new hard realities. Now, what does that mean for us? Well, our local data that was more specific to all pediatric patients, that was specific to a certain type of rhythm, is pretty unequivocal. The Japanese data is interesting, but it's really sliced to a pretty narrow patient population. It's really pretty heavily data mined. It is still well powered, but I don't think it's generalizable to our healthcare system or necessarily to pediatric patients less than 7. So I would put a little bit less weight on that, but it is interesting as we talk about these hot potatoes and hot topics to see what's evolving and where and how it's evolving. So we did it. We ran the call. We navigated the safety events. We did all the stuff. It's time to transfer care. One last snag, right? Remember, it had to be complete, efficient, and timely. Timely, nailed that, right? Our handoff occurs when we meet someone to hand the patient off to. So we only have to focus on complete and timely. Now, researchers are sneaky and they video recorded the EMS handoff to the hospital team and I'm going to air quote again, critical pediatric patients. And they reviewed 68 cases of handoff. A couple of things jump out at you right away. So when we look at this slide that says complete, what you're seeing is the percentage of the 68 cases that reported that specific metric. So our best completion is telling someone the chief complaint, which we did almost 9 times out of 10, right? What was wrong? What we did, also very important, about 8 times out of 10. What you see living at the bottom, respiratory rate, heart rate, pulse ox, and blood pressure, is a full set of vital signs that we don't reliably report, and that significantly matter, right? We have said for far too long that blood pressure in that kid, that doesn't matter. And that's weird because we define shock as compensated or hypotensive, and you would need a blood pressure to do that, right? Respiratory rate is incredibly predictive of work of breathing, respiratory distress, crashing kids that are becoming bradypneic and slowing down, but we can't make it up. You have to actually measure it. Pulse oximetry, blood pressure, weight is a critically important data point for resuscitation and weight-based dosing. We have to record that, either an estimate or a known actual weight. So there are things that we can do to improve the completeness of our reporting. Well, what about the efficiency? So 68 recordings, right? That's the beauty of video recordings. They cut both ways. 51% of the time, the EMS crew was interrupted by the emergency department staff before they could finish the report. So the next question then, right, is why? Always ask yourself why. So 40% of the time, the question was from the ED physician about something that someone had already said, that you had given them in the report that just nobody heard. 65% of that was an ED physician asking you for information they felt they needed timely that you haven't yet communicated. And I just thought it was interesting, so I put on the slide to remember to share that there is no statistical difference between cardiac arrest and non-cardiac arrest events when they thought about the completeness of handoff. Now they're all critical, so it was all a timely handoff, but they were not all necessarily active resuscitation, which would certainly crank it up a notch. The inefficiency of communication in one of these domains occurred in 87% of all EMS handoffs. So how do we improve that? Well, I think we've done some of those steps. And I know in your region, we did some of those steps even back when I was still there, is that we dedicate time for that handoff. So you might have 20 seconds. You can say a lot in 20 seconds, but to get there and to make sure that it's complete and concise, we should have some kind of script. The important element here that I think we often overlook is that we should share that script with the people we're talking to, right? The interruption from the physician can be avoided if that physician knows when this information is coming. Maybe it's something she wanted that's 3 points down in your 20-second shout out, or it's something that she knows she missed because it would have been 2 points up in your 20-second report. But having a shared script, knowing that we're all on the same sheet of music, right? And then you want to get the proper info to the proper team member. That immediate care team only needs the high points. There's going to be a nurse that's going to need all the points. There might be a social worker that we want to talk to about family contacts or suspected abuse and neglect and how we were going to report that. There might be a chaplain that we're trying to identify and point to the family. You know, there's all these people that make up a care team. So the right information to the right person will help you be timely, complete, and efficient. All right, what do we have? 8 minutes. I got this. 8 minutes. We're going to go real quick. Pediatric submersion events. This is Spencer Elder. For those of you that aren't laughing, that is the cover album from Nirvana. He was 4 months old in the picture, but we're going to pretend this case is a 4-year-old. The 4-year-old male found unresponsive in the pool by his mother. It is a late day in July. It is sunny. It is hot. It's 90 degrees outside. Mom said, hey, I've been inside for 5 minutes. I ran inside. I was trying to grab a couple things for snacks to bring out by the pool, and I found him submerged in the pool. It's just a chlorinated standard pool, nothing fancy schmancy. So we want to go through first on our way there, right? And say, what are my survival calculations? How am I going to control the chaos? So we said he's 4. So if I use a 4-year-old, he should be 16 to 8 kilos, 16 to 18. He should be a 5.0 endotracheal uncuffed tubes. My system here at Remsa Health uses all cuffed tubes. If you've made that transition or are considering, just remember that equation comes down half the tube size. So he would be a 4.5 cuffed endotracheal tube. The depth is the same at 14. And my epi dose is 1.6 to 1.8 milliliters, 1 milligram and 10 cc's, or 0.16 to 0.18 milligrams. So I'm going in with that information. That's how I'm going to maintain control. I got it on tape. I got it on my leg. I'm ready to roll. So I go in. We're 5 feet away. I'm doing my assessment. I'm evaluating, identifying, intervening. And the first thing that I see from 5 feet away is a child that mom has pulled out of the pool. He appears to be cyanotic. He appears limp. He is cool to the touch. He is pulseless, and he is apneic. So I don't have to do any more evaluating, right? I don't have to do any more identifying and intervening. Well, I guess I do have to do that part. But I don't have to do that circle anymore because we are in cardiac arrest. So I can think about, as I'm kind of playing this through and I'm thinking about how do I manage this cardiac arrest, or even from the time of dispatch, what could be the differentials for a kid unresponsive in a pool or found in a pool? And drowning terminology is a little bit different now. If you die, we say you drown. And if you didn't die, then we say you had a non-fatal drown. We used to have a near drown. Now it's a non-fatal drowning. It's more congratulations for surviving. A seizure could have caused that to happen, right? Maybe the child has a seizure disorder. Maybe it was a trauma of some kind. Maybe there's a glucose imbalance that led to an altered mental status or an intoxicant exposure. Maybe the kid had hypothermia from a cold water exposure that led to the drowning, or maybe there's a non-fatal drowning that's compounded by hypothermia, because even if the water is really warm, it's not core temp, right? Anything under your core temp is going to make you hypothermic. If you become the temperature of the really nice 84-degree pool water, you are ice cold. So always keep that in mind. Cardiac arrhythmia, it could have been a precursor, or child abuse, right? Intentional drownings are heartbreaking and they happen. So you got to keep those kind of things in mind. An individual that drowns, there's a certain pathophysiology that happens, right? When you become submerged, you're a victim of a submersion event, you take that inspiratory reflex and you're going to bring in some water, and one of two things or possibly both are going to happen. You're either going to aspirate some water directly, which will wash some of the surfactant out of your lungs. Remember, the surfactant is the lubricant that stops the alveoli from being stuck together, and so they can slide back open. And if I stick together, I can't get good gas exchange, and that aspiration and surfactant washing leads to hypoxia because it's a big ventilation perfusion or VQ mismatch. The other thing that'll make you hypoxic is that when that water hits your airway, to protect yourself and to prevent the aspiration, you go into profound laryngospasm. So profound that you can't get air past it. And then you're going to become increasingly hypoxic. And if you've been in a class with me before, we talk about hypoxia as a tiered thing, right? So books always start with tissue hypoxia, but the hypoxia really happened at your cell. It was your cell that didn't get oxygen. And groups of cells are called tissues, right? And groups of tissues are organs, and groups of organs are organ systems, and groups of organ systems are people on Bumble. So that cellular hypoxia very quickly can become end organ failure. and end organ failure is going to progress to death. And all of that is going to be compounded by the water temperature and the hypothermia that you're experiencing. And with hypothermia, and I know I apologize for not adding a ton of depth here, but with hypothermia comes coagulopathies and acidosis. So there's just a potpourri of problems. There is this ongoing from the immersion, hypoxia-driven end organ response, compounded by hypothermia, acidosis, coagulopathy, that leads to death, leads to drowning. So what do we do? Well, the trio in the back are mother, jugs, and speed. And if you're not familiar, Google it, thank me later. But the treatment for these things is not mother, jugs, and speed. It's stay where you are, set up shop, let's get things done. We didn't have to perform the rescue. Mom got this kid out of the pool. There is an emphasis for these patients on ensuring ventilations. Cardiac arrest was driven by the respiratory arrest. So we don't want to do continuous chest compressions. We want to do, if we're doing CPR, in tandem with ventilations. If we're just doing ventilations, then we might want to consider positive pressure ventilations. You could apply, if your protocols permit, CPAP or BiPAP to this child that's breathing spontaneously. If we're bagging them, we should add at least 5 of P, and protocol driven, oftentimes up to 10, because the surfactant that's gone, we want to force the alveoli back open. Using positive pressure ventilation will decrease that VQ mismatch. There is no preference. We reviewed almost 2,400 drowning cases. There is no preferred airway device. None of them had any statistical difference in terms of neurologically intact clinical outcome. Bag valve mask is completely acceptable. Remember that your ACLS protocols might be shifted to include ACLS in the presence of hypothermia, that we should do some contaminant rewarming. So we should actively try and rewarm these patients. Orogastric tubes, if you're using them, should be placed with any endotracheal tube. We were talking a little bit about bag valve mask ventilation and how bag valve mask ventilation causes distension of your stomach. An orogastric tube allows that to be relieved. And consider and usually discard spinal immobilization unless there's obvious signs of injury or concerning mechanism. Again, 2,400 cases, 0.5% of those patients had a cervical spine injury. So very low incidence, shouldn't be a factor. And the last thing that comes up, I just want to dispel this myth a little bit. Does the water matter? Fresh water versus salt water, right? And we thought, wow, if you have salt water, your electrolytes are going to get messed up and all your blood volume is going to shift around. And it turns out that actually doesn't happen. So most drowning victims take on about 3 to 4 cc's per kilo of water. To create shifts in your blood volume, you would have to take on about 11 cc's per kilo. To create shifts in your electrolytes, you would have to take on about 22 cc's per kilo. That is way beyond normal drownings. So unless you are pulling someone out of the Dead Sea, you should be just fine. We don't have to worry about that. What we do worry about with the water is what is the temperature and are there contaminants? Because those things will influence the outcome. Very quick bit about self-care. Think about stressors, acute and chronic stress. Engage peer support, engage critical incident management, engage national resources. We all know someone that is directly affected, or we have all lost a friend. I've lost several to suicide amongst my peers, my coworkers, my friends, my mentors. It is heartbreaking. So I know we talk about a million kinds of self-care, right? Drink water, get lots of sleep, avoid caffeine and alcohol, all of those things, which are kind of the opposite of what a shift looks like. But I personally have found some comfort in this. We do this at Remsa Health. We offer a meditation program. Cognitive-based therapies guided by meditation have been proven in several studies to decrease stress, to decrease cortisol, to improve chronic stress, to help you maintain focus during periods of acute stress, and to help you regulate emotional response. And all of those things are critical to you providing the best care you can at the scene of that pediatric emergency. I would offer you time to meditate, but I've already run over. So a couple of quick slides. Happy EMS week to all of you. I tremendously appreciate everything that you do for your communities that you serve, for the individuals that are fortunate enough to receive care from you. So thank you very much. You are indeed awesome. That's me. That's my contact information. That's my cell phone, call, text, write, email, whatever you'd like to do. I'm happy to take any questions. I'm happy to follow up. I hope you have an outstanding rest of the day. Thank you guys all so much.